afternoon. I really thank very much the organizers for inviting me to this important event. I'm going to speak about the differential diagnosis and the role of functional studies in NMOSD and MOG and MS disease. These are my disclosures. And I would like to start by saying that concerning functional studies, I'll be speaking about evoked potentials, which I think are the only laboratory tool that measures conduction resulting from demyelinating lesions and can allow measuring also remyelination. And I will concentrate today on the visual evoked potentials because I prefer to concentrate on optic nerve abnormalities and optic neuritis in the course of the three diseases. And this is because the retina is considered as a window of the brain, not only for physiological and anatomical reasons as it is an extraflexion of the brain, but also because now we have the tools to examine the retina with OCT, optical coherence tomography, and we also have functional studies, mainly visual evoked potentials, allowing to record the time required from the retina to the brain, and so to assess the presence of demyelination resulting in slowing of conduction. And the visual evoked potentials are quite easy and economic tests, allowing to test the two eyes in separate times, so to make a comparison between conduction in the two optic nerves. And we have also new methods for testing nervous conduction along the optic nerve, and mainly they consist in multifocal stimulation, allowing separate assessment of small segments of the optic nerve and by consequence of the retina. And with visual evoked potentials, we can also, after removal of conduction block in the early phases of optic neuritis that can sometimes cover the visual response, especially after steroid treatment, particularly in people with MS, it is almost always possible to record an adequate cortical response, and so to have information about the speed of conduction and the presence of demyelination. Optical coherence tomography in turn allows to measure the thickness of the most eloquent retinal layers, consisting in the retinal nerve fiber layer and ganglion cell layer in the plexiform layers, although also the inner nuclear layer can provide interesting information. And I would like to point out that this test, although being quite non-invasive and not intrusive for the patient that well tolerates the procedure, can allow an almost histological spatial definition. So it is really an in vivo histology that we can perform. So as I said, the most important and interesting layers for the neurologist are the nervous layers, although the presence of the Muller cells in the inner nuclear layer can give information about inflammation, especially in the post-acute phases of optic neuritis. And the two most important procedures in OCT are the peripapillary scan, circle scan, allowing to measure the retinal nerve fiber layer, which is composed of axons leaving the ganglion cells and merging towards the optic nerve head. And the ganglion cells are best studied in the macular scan, allowing actually to measure both the ganglion cell layer and inner plexiform layer, which is the synaptic layer. And after optic neuritis, we can see that the visual evoked potentials are immediately lower in amplitude and increased in latency, and they gradually improve as a sign of removal of conduction block for amplitude and remyelination concerning latency. But we have an opposite paradoxical behavior of retinal nerve fiber layer that can be initially increased in thickness due to edema that is reflected also in swelling of axons in this layer. And as the degeneration takes place, we can see a gradual decrease taking place in the first 3 or up to 6 months. And the difference with the ganglion cell layer is that the ganglion cell layer becomes thinner even in the first 4 weeks. So timing of the assessment is quite important, as we can gather different information according to this to the time. And the fact that by 4 weeks the ganglion cells are basically reaching a plateau in degeneration also suggests that any intervention targeting neuroprotection should occur well before the 4 weeks after optic neuritis, because at 4 weeks most of the ganglion cell loss has already occurred. But in the chronic phase, as there tends to be a residual VEP delay, especially in older people, while in adolescents the VEP recovery could be almost complete. There is a correlation between the amount of residual VEP delay and the amount of retinal nerve fiber layer loss that occurred in the acute phase or within the 6 months. So in MS, demyelination comes with axonal loss and vice versa. And this is not always the case for NMO, for example, where you can have important axonal loss despite a low amount of demyelination or low amount of delay. We will see it later. But should we make a choice and choose between visual evoked potentials and OCT? Actually, it's better to have them both because they provide different information, as visual evoked potentials provide information on the conduction in the living and demyelinating axons, while OCT is providing information about the amount of loss of axons. So it takes longer time. So they're almost equally sensitive to VEP only in the chronic phase, while in the acute phase, you may see VEP delay without still abnormalities in the OCT. The possible advantage of multifocal VEPs compared with full field VEPs could also be that not only multifocal VEPs can provide information on separate segments of the optic nerve, but also that they can analyze a wider region compared with the full field VEPs, where the peripheral regions of the visual cortex generate potentials that can cancel each other due to topography and anatomy of the visual cortex, while this is not the case for multifocal VEPs. So in some cases, with only a small sector of the optic nerve that is involved, it is possible that the full field VEPs are normal, while only at the multifocal VEPs, even in the presence of a documented lesion at MRI, could be the only physiological and functional test of normal. Another reason to complement also multifocal VEPs could be the fact that in case of partial lesions of the optic nerve, particularly in the periphery, you can have a normal full field VEPs where only by investigating the involved sector, you might have a good correspondence with the visual field testing. And again, the full field VEPs are blind to optic tract lesions, as in this example, where half of the fibers are preserved, and so they give origin to a normal full field VEPs in both eyes, while only at the multifocal VEPs, we can see that half of the axons in each optic nerve are not functional because the lesion is in the optic tract. But we can still use the standard BEPs to answer some basic questions, especially in our everyday practice, being also much faster and less expensive and more widely diffused compared with multifocal BEPs. For example, we might have a question in case of a patient with new visual symptoms, but with former and previous optic neuritis. Is this a new optic neuritis, or is this, for example, Utah phenomenon due to summer heat? We know that in the case, this is an experimental evidence, in the case of demyelinated lesion, giving origin to delayed action potentials, these are the only ones that are affected by temperature increase, while the non-demyelinated axons are not affected by temperature increase. And this is the case also in humans. We have here a patient with previous optic neuritis with delayed visual evoked potentials who told us that he was having visual blurring after running. So we asked him to run in place, and after 10 minutes running with increased temperature, we noticed that there was no delay, further delay in the VPs, but only decreasing amplitude. So if a patient with the previous optic neuritis comes back with visual blurring in the summer, we can easily perform visual evoked potentials and check whether the latencies are the same as before at our last visit, or it's just a matter of amplitudes. So in this case, we can reassure the patient that most likely the issue is just an increased temperature, or if there is a new demyelinating event with further increase in latency. But there are more difficult questions to answer. At the time, for example, of a first optic neuritis, we might ask ourselves whether it is optic neuritis or other condition, for example, NMOSD or anti-MOG antibody syndrome. And so in the case of the difference between MS and NMO antibody syndromes, for example, we know quite well now that lesions tend to be longer in NMOSD. There are also other differences if we consider OCT. Besides the fact that visual acuity and contrast sensitivity recovery tend to be less complete in NMO compared with MS, and that altitudinal loss tends to be more common in MS, in NMOSD compared with MS, we can also focus on peculiar differences in OCT examination. For example, in NMO, the reduction of RNFL thickness is basically attack related, although we will see that there is a small longitudinal neurodegeneration also in NMO, as from our findings, for example. And that subclinical occurrence of abnormalities in RNFL thickness are most frequent in people with MS. And we can also consider that the people with MS tend to be affected mostly in the temporal region, while the superior and inferior quadrants tend to be mostly affected in NMO. And there is another phenomenon, which is macrocystic macular edema, which tends to be more frequent in people with NMO optic neuritis compared with MS. So macrocystic macular edema in the internuclear layer is much more frequent in people with NMOSD or with positivity of anti-aquaporin 4 IgGs compared with people with MS, where it is reported only people in 5% of people, and it is associated with poorer visual outcome and with more severe retinal RNFL thinning. And here we can see an example of a person with optic neuritis after NMO with widespread involvement, and that tends to be more evident in the superior and inferior quadrants compared with a typical patient with MS with a more prevalent involvement of the temporal region and with less degeneration of the ganglion cells, as we can see here in the bottom figure. But we can consider also to add the functional assessment with visual evoked potentials, because we can consider that as in MS, the main target is myelin. In neuromyelitis optica, the main target are astrocytes, so this is not a mainly purely demyelinating disease. So we already said that the lesions tend to be longer in people with NMOSD compared with people with MS. And in this study, the comparison between people with anti-aquaporin 4 antibody positive and negative showed that similarly, the visual evoked potentials tend to be more frequently absent in people with antibody positivity compared with people who are antibody negative, and they were, I think, mostly people with MS, where the VEPs were more frequently delayed than absent. And also in this Brazilian cohort, it was shown that people with NMO tend to have more amplitude abnormalities compared with latency abnormality, which is only delayed by a few milliseconds compared with the delays in people with MS that we know tend to be of several milliseconds, as we will see later. Here in this study, in a German cohort, it was actually demonstrated that there could be some subclinical delays in eyes without optic neuritis in people with NMOSD, and that there could be a delay that is quite important even in eyes with optic neuritis in people with NMOSD, particularly in people that are anti-aquaporin positive. And here we come to our Italian cohort, where we compare actually both tests, not only VEPs, but also OCT, to check whether the discrepancies between studies might be related to different involvement of the myelin and axons in different cohorts. And so to put things together, we started to observe that similarly to the review I showed you before, there is a higher tendency of important severe axonal loss in people with NMOSD who had optic neuritis. We have a cutoff here of 60 milliseconds, 60 micrometers that is almost never reached by people with MS who had an optic neuritis. But there could be some involvement in people with MS and without optic neuritis compared with healthy controls. So again, also here there is a quite important subclinical involvement of optic nerves in people with MS, which is less evident in people with NMOSD, where the loss of axons tends to be attack-related compared with disease-related. So less subclinical involvement in NMO. And this is quite similar if we consider VEP latencies. Not so evident subclinical involvement in people with NMOSD, while there is quite relevant involvement in people with MS even without optic neuritis. But if we focus on eyes with optic neuritis, we have a cutoff of 150 milliseconds, which is almost never crossed by people with NMOSD and optic neuritis, while it is quite observed in a few percentage of cases, but in few cases it is there in people with MS. So if we consider the relationship between axonal loss and demyelination, so the correlation between RNFL thinning and delaying P100 latency of the VEP, we see a good correlation only in the cohort of people with MS, which is not quite there in people with NMOSD, where we can observe quite a relevant thinning without the corresponding delay in the VEP, while delay in the VEP in people with MS comes at the expense of more relevant axonal loss. And so if we combine the deviation from the norm of the VEPs and of the OCT, we can find quite a good separation between the cohort of people with MS here and the cohort of people with NMOSD here, where the axonal loss tends to be prevalent, while in the people with MS, the VEP delays tend to be prevalent compared with axonal loss. So we can disentangle the physiopathological mechanisms of the two diseases, not with OCT only, not with VEP only, because there is a sort of overlap between the two conditions. But if we combine the two information, we can have a better separation between the two diseases. So we can consider that in NMOSD, we have a prevalence of axonal loss compared with demyelination, while the opposite is true for people with MS. And this can explain the better visual outcome in people with MS after optic neuritis, because there are still viable axons that are prone to remyelinate. So this is also coherent with the data on visual loss that we will see later. From this paper, quite an interesting paper that compared not only visual outcome, but also brain and optic nerve MRI in people with MS with anti-aquaporin 4 antibody syndrome. And here we see for the first time the third disease, which is the syndrome associated with MOG IgG positivity. And here we can see that while it is quite more prevalent, the absence of brain MRI lesions in people with MOG IgG antibodies, in this syndrome, the involvement of the optic nerve tends to be more frequently bilateral compared with MS, but also bilateral involvement can be seen in anti-aquaporin 4 antibody syndrome. Although there is quite a different location of the lesions. For example, in anti-MOG syndrome, there is the inflammation tends to be closer to the eye with more frequent optic nerve head swelling compared with anti-aquaporin 4 optic neuritis that tends to involve more frequently the posterior optic pathways. So optic tract and optic chiasm, as in this figure. In the next, so in this slide, we can see that bilateral optic tract tends to be involved, similar to the chiasm, more frequently in people with anti-aquaporin 4 antibodies compared with both MOG and MS. And so if we compare the position, the site of the lesion, of the optic nerve lesion, we can see that we have a more retrobulbar involvement, more frequent in MOG, IgG antibody syndrome, while it tends to be more frequently intracranial in anti-aquaporin 4 antibody syndrome. But They have similar length of involvement, which tends to be higher in MOG and anti-aquaporin 4 compared with the optic neuritis that we see in MS, which tends to be more frequently focal. Although there is not a straightforward criterion to discriminate between the three conditions. As we can see, there could be also longitudinal lesions also in MS. And this is why it's quite important to combine different information, including functional information from optic nerve conduction and OCT. Again, as we can expect, people with MS tend to have a better recovery compared with people with anti-aquaporin 4 and with people with MOG IgG antibodies that are considered classically to recover better compared with anti-aquaporin 4. But we should not be always too optimistic about the full recovery that is frequently described in people with MOG IgG antibodies, because the full recovery is less frequent in this condition compared with the people with MS. And also, we have to consider that in people with MOG IgG antibodies, there could be a relapse that further can compromise the visual outcome and the retinal nerve fiber layer thickness, which is an important aspect of axonal reserve. So in the end, if we wait for multiple optic neuritis to occur, and we are not considering quite well enough the importance of early diagnosis and timely initiation of immunosuppressive therapy, our patient with MOG IgG antibody may end up with a similar amount and similar severity of retinal damage compared with anti-aquaporin 4 antibodies. And so in this important study, it was shown that the burden of disease on the optic nerve can be associated with the accumulation of relapses in the same optic nerve in people with MOG IgG antibodies, while even after a single relapse in people with NMOSD, we can have a very severe damage. And similarly, especially in people with more than one relapse, that could be quite a frequent presence of macular mycocysts, similar to what we have seen in people with the NMOSD. Also in this paper, in this case series of 5 patients, the visual outcome was not favorable. And we can see here one of our patients with the typical VEP delay. She has MS, and the delay is quite important, 150 milliseconds, without important edema and without further axonal loss even at follow-up, which is not shown here. While on the opposite, even after one single episode of optic neuritis, one for each eye here in this NMOSD patient, we have a very important loss of axons in the retina bilaterally, and almost no recorded VEP trace for either eye. There is only one residual portion of the optic nerve, which is the peripheral portion, that can give origin to a response which is not so pathologically delayed. So again, we can have a dissociation, as we shown before, between the important axonal loss and not an important demyelination. And this is a case of a girl with MOG IgG antibodies who had repeated episodes of optic neuritis. She was initially treated as MS, and of course she kept relapsing with optic neuritis in both eyes, and she always had a good recovery in the visual function. But it is important to check the OCT because despite a good visual recovery, there was still a minor VEP delay. So even the VEP traces recovered well. But every time she had an optic neuritis, she lost a few axons. And here we have a quite severe axonal loss. 70 microns of retinal nerve fiber layer globally are quite an important loss if we consider that the normal values tends to be 100, 110 microns. And there are no data about, not so many data about the continuous axonal loss or ganglion cell loss that we can have in the course of the disease in people with NMOSD and anti-MOG syndrome. We have more data in people with MS. For example, in this first study, we could see that people under treatment with natalizumab had longitudinal ganglion cell loss less important compared with people with the first-line injectables. And in our study, we demonstrated that the no evidence of disease activity is associated with better preservation of retinal nerve fiber layer compared with disease activity, even in the absence of optic neuritis, in the sense that poor control of disease activity leads to neurodegenerative or inflammatory mechanisms taking place in the optic nerve, despite no evidence of optic neuritis. So we can consider that poor control of the disease can be associated with continuous neurodegeneration in the optic nerve. So we can use OCT also to monitor treatment response if validated in larger cohorts. And also in people with NMO, there is some demonstration that the retinal nerve fiber layer can become thinner over time, even in the absence of optic neuritis, and that's quite important. And in our study that we see here, we also found longitudinal decrease in the thickness of retinal nerve fiber layer, even in people with NMOSD. But when we disentangle the results concerning disease activity, we found that in NMOSD, the subclinical abnormality, the subclinical loss in retinal nerve fiber layer was associated with disease activity. So again, poor disease control can prompt neurodegenerative mechanisms also in people with NMOSD. We can consider that in people with MS, it is possible also to promote remyelination, as for example in this trial using clemastine, but little is known about the possibility to remyelinate optic nerve lesions in people with anti-MOG syndrome, for example. So we need to collect more data on this. So to conclude, we can consider that the combination of neurophysiology, mainly evoked potentials, and OCT can be of great help in the differential diagnosis between these three conditions, particularly if you want to differentiate between MS and NMOSD. And MOG lays in between these two conditions, considering the severity of axonal involvement and which is more similar to what we see in NMOSD, and the severity of demyelination and subsequent recovery, which is more similar to what we see in MS. And so we can combine these two for the diagnosis and differential diagnosis. Little is known on the prognosis of NMOSD and anti-MOG syndrome compared with MS, where we already have some data, although I did not show them to you. But we already have data that these two techniques can be useful in monitoring disease activity and in monitoring function and remyelination. And we need to collect more data for people with anti-MOG syndrome. And with this, I thank you for your attention.